We actually joke on the product team about things that are because healthcare, like only because healthcare do I have to think about
I love that.
eFax, right? Like stuff that a product manager wouldn't have to think about in any other sector. And sometimes it's compliance and regulatory. Sometimes it's just that healthcare is way behind with respect to technology adoption. I am still on faculty at UCSF, where we really just got rid of pagers pretty recently.
How recently?
We finally axed them like a year or two ago.
I wonder who was the biggest holdout, the drug dealers in San Francisco or the hospital?
Oh no, the drug dealers moved on way before the hospitals. That's the thing.
Hi, everybody. Welcome back to Lifers. Our latest lifer that I'm so excited to introduce you to is Dr. Ari Hoffman. And he has this really unique role in the world of digital health where he oversees both clinical and product. I often have this kind of rubric of thinking about chief medical officer or chief clinical officer roles that there's so many different types. Some people think it's kind of all one and the same job, but you can have product oriented clinical, you can have sales oriented, you can have marketing oriented, you can have clinops. But Ari is somebody who has chosen the product path in his career. And he is, a veteran of both tech and health, which is why I love having him on. We have so much to talk about on this episode. So I'm going to kick it off by just saying, hi, Ari. Thank you so much for joining us.
Hi, Chrissy. Thanks for having me.
Okay, so there is endless amounts of stuff happening right now. And I wanted to kick us off by asking you really about just what you think is going on in the world of just policy around health tech, because it's just every day I'm kind of reading about industry friends, people I've known for years that come from digital health going into roles within the administration. I don't know if you saw that Shantanu Nundy, who is the chief medical officer of Accolade, just joined the administration, and lots of others from the industry as well. I think Chris Klomp is another good example, who was on the board of Maven Clinic. So very much a digital health lifer as well. So I wanted to ask you what you're seeing in terms of policy right now that makes you feel like there are either headwinds or tailwinds for the industry.
Just a hard time to answer that question, given sort of the uncertainty of the Trump administration overall and some of the unpredictability we've already seen. But I think there's a mix of both headwinds and tailwinds in the policy space. And I do think there is some reason to believe that some good things will come out of the current momentum in all of the change, right? So people have heard of the One Big Beautiful Bill, and we're expecting to see pretty big cuts to the number of people insured in the country. That's, in my view, a bad thing. Those cuts are coming through primarily through Medicaid. That can have lots of other impacts on the rest of the healthcare ecosystem. So it's not just if I'm not on Medicaid, I'm not affected by that. We can talk more about that if you want to.
Yeah, we've been talking about that a lot on recent episodes, and you're in the employer landscape. So we had a guest on recently who made the really astute point that it has a big impact on commercial as well when you cut Medicaid, because if your health system is going to start losing even more money on Medicaid, you have to find ways to offset that. And where do you do that? But on the commercial side with your patients and populations there. And that has a big impact on employers who have already been seeing so much accelerating healthcare costs and now potentially facing more of that. I just don't, at some point, you wonder how long it can even continue before they start saying, I give up.
The employer-sponsored space has been feeling that squeeze particularly hard for a long time. And I think, we had this grand policy experiment, if you will, in the United States of shifting costs to members through the idea of consumer-directed health plans, which I think is kind of euphemistic to think that it was consumer-directed to say, oh, well, if you just have more skin in the game through higher deductibles, then people will just be these brilliantly savvy shoppers of healthcare services. And then all of a sudden, everything will work out. And that has not been the case, right? So by shifting costs to members through things like higher deductible health plans, people just avoid healthcare, and they avoid actually the high value care as much as they avoid the low value care, which means just less access to care. People avoid the whole thing. And it's just hard to be a savvy shopper of healthcare. I do think some of that is changing. We have tools today that we didn't have when people started this whole foray into high deductibles, but you're absolutely right. There's just not that much more room to squeeze out of it. And there are lots of other ways. I think health systems will consolidate, more, and that will have impacts on rising prices, which will be felt by everyone, not just the commercial space. But that's like one piece of policy. You asked a pretty broad question about like what else is going on in health policy, and maybe are there any tailwinds involved as well. And I think there was an announcement just at the end of last week about the Make Health Tech Great Again move towards this idea of a more connected healthcare ecosystem.
It was so funny, by the way, how many digital health CEOs were like calling their lawyers and their policy people being like, why was I not included in this? And like, why was I only included in a portion of it? It just felt very random. Like the companies that were there and not there.
It is a funny mix. I mean, it's like big companies like United Health Group, and then some startups and much smaller companies as well. And a mix of the data network companies like Innovator and consumer app type companies like Curai.
You got to wonder if the administration was like, we have a few venture firms that we know, we'll just call them and get the portfolios companies to come. There was definitely some portfolio concentration.
I also think like, it's not really, I don't know how many people nerd out on things like TEFCA, which is
I do.
Which was part of the 21st Century Cures Act. It passed in 2016, but the idea there was to set some standards around interoperability, as you well know. And it's funny to me because there wasn't any real mention of that in any of the materials that were put out in the recent announcement last week. And so it's unclear to me whether that's just, if this is like a whole new attempt to create better or newer interoperability standards, or mostly just trying to take credit for stuff that's already been in flight and pretend that they invented it or reinvented it. But in any case, I do think those are good moves for us to be thinking about real interoperability standards. I mean, healthcare is in desperate need of some deep standards that are actually adhered to, that get us out of faxing information and, the sort of veneer of interoperability that I think we still have today. Lots of great strides have been made, and it is hard. Interoperability is hard, but there's a long way to go.
Yeah, it's definitely not a solved problem. And one of the other interesting tailwinds that we saw in OBBB is around this allowance that employers will have in 26 to provide direct primary care to their employees on high deductible health plans.
Yeah.
Which, to your point about shopping, it's actually pretty interesting because for a family you get $300 a month, and for an individual $150. So if you think about the package or the bundle of services that you could shop in a primary care context, and primary care in that definition seems quite broad. Like, I wonder if it could include things like longevity and health optimization and some other things that are very trendy at this present moment. So that actually seems like we are moving into a more shoppable direction. But then to your point, like there are things that I could shop. Like if I just want, something very, like if I have pink eye and I just want to shop an easy way to get a prescription for my pink eye, that seems very shoppable. But if I get diagnosed with, stage 4 breast cancer, I don't think I'm like really in the shopping mindset per se. I'm probably thinking, how do I get to the best doctor I can possibly get to?
Yeah.
And I'm probably feeling very vulnerable and scared in that moment. And I don't think that it's the same mindset as like, let's go buy an iPad. It's just not. And so how do you make sure the shoppable option like is used in the right context versus one that I think frankly takes advantage of people?
This is a really good question, Chrissy. I think shopping in healthcare means different things at different times. I think you said it really well. Like, it's context specific, right? So, which is like sort of the worst answer is it depends, but that's the truth of the matter. And our own user research at Collective Health, we've seen how differently people view things like, what does quality mean when you're looking for a provider? In primary care, people tend to weight the relationship component, which means for a lot of people, a lot more about sort of the bedside manner, if you will, and the ability to communicate and trust a provider and to have a relationship with someone that they can sometimes even relate to on a demographic or personal level. Whereas, like you said, if you need neurosurgery or really complex cancer care, people tend to really weight experience right? The volume of patients that somebody sees matters for especially surgical procedures, things like certain credentials or where they went to school or what kind of institution they're at. And they're willing to go further, right? So the convenience matters less. When you put together these different components of quality, one of the approaches we've taken is to put together sort of the convenience, the cost, and the various domains or dimensions of quality for people to be able to make those kinds of informed decisions, knowing that the way that they're going to make that decision will vary depending on what they're shopping for.
I like that. I think that makes a ton of sense. So getting us back to just like the theme of the pod, which is the lifer idea, I wanted to just circle back a little bit to your career in healthcare and also the journey that brought you to Collective, which is the company that you now work. But also, I would say at this point, I would call Collective an OG, in the industry. The year that I believe the company was founded was 2013, right? You would know better than me. But so makes me feel old because I was around when Collective launched and first raised money. And, it's been more than a decade, 12 years. And Collective, like many companies at that stage, is not a public company. It's still a private company. It's still kind of trucking along and people haven't exited yet. And that's true across a lot of the industry right now. And I have this joke that like, if you want to make money, you should just probably get into like crypto and not healthcare because it just seems like a much faster path. But do you have any thoughts on just like the people that get attracted to this kind of work and looking at just this fact that so many of the companies that got started in the kind of 2010 to 2013, 14 era, they're still, building. They're still in a mindset of, finding their way with big customers and not public yet. Like, what do you think that says about the pace and the kind of skill set or temperament required to do health tech?
I mean, it's slower than other technology sectors, right? And I think we joke on the product team about like things that are because healthcare, like only because healthcare do I have to think about
I love
like,
that.
eFax, right? Or when, like stuff that a product manager wouldn't have to think about in any other sector has to be considered. And sometimes it's compliance and regulatory. It's a heavily regulated space, right? Whether that's HIPAA or other regulatory considerations. Sometimes it's just that healthcare is way behind other sectors with respect to technology adoption. I am still on faculty at UCSF, where we really just got rid of pagers pretty recently.
How recently?
I want to say we finally asked them like a year or two ago.
I wonder who like was the biggest holdout, the drug dealers in San Francisco or the hospital?
Oh no, the drug dealers moved on way before the hospitals. That's the thing.
Those guys are like innovating on Signal now.
Oh
like,
yeah. The pager was long gone. And we're still keeping the fax alive. And there's, our head of engineering, whose name is Ganesh, he likes to joke with me. He doesn't come from a healthcare background, has been in a number of different technology leader positions. And one of the things I love about working at Collective is working with people from these different backgrounds who are energized by our mission and connect to the importance of doing something about making the healthcare experience better. But he says like when sometimes he just has to think back to 25 years ago. So he'll say like, how would I have solved this if I weren't in healthcare in 2000? That's what's going on in the ecosystem. Yeah, that's kind of how bad it is sometimes.
What's your number one, because healthcare, with any product feature that you've been involved with, where if it wasn't healthcare, you would have done it completely differently and it would have been way more seamless?
Oh, I mean, there are a number of provisions of HIPAA that come to mind. And I think HIPAA is a good thing. I mean, I think it's good to protect people's protected health information, no doubt. But there are certain elements of that do get in the way of just a meaningful and seamless member experience. I mean, we've had issues where, you just think about what you can put in front of somebody in a text message and what you can't, and how much you can say, even things like the data retention for HIPAA, like you have to maintain records for a certain amount of time. We had a whole thing about that being at odds with the data deletion on the application, on the mobile app, and how trying to meet Apple's data deletion standards and HIPAA were seemingly at odds. And we had to work through that to be able to let people like register in the mobile app and also be able to appropriately retain their records while showing data deletion, like stuff like that, where it just gets like, you would never have to think about that in any other mobile app registration outside of our industry.
It makes it so difficult to in one of my old companies, we used Accolade for navigation. And I liked Accolade, but it was like every time I had a benefits question, having to log in through multiple kind of security protocols for a basic question, like, is this thing covered? And you're sitting there at the doctor's office and they're asking you the question and you're like at the front office and people are trying to get past you and you're super stressed out. And then you're trying to log in to get a basic. And I'm like, why is this not a Teams or a Slack integration where I can just message, hey, Accolade, what is my, deductible on X, Y, or Z? And they could just tell me, because it doesn't, it shouldn't be HIPAA to ask questions like that. But I don't think that we've even really figured it out yet, how to do, something as basic as that.
Yeah. I mean, building out eFax capabilities, that's another one. I mean, all these things that are sort of foisted upon us in the added layers of complexity that we wouldn't otherwise need outside of healthcare. But it's also, I think the thing that brings really great people who are so mission driven to companies like ours.
And it's maybe a moat. Could you argue it's a moat to the complexity in itself is a moat?
Yeah, I think absolutely. And in sometimes it's a bad moat. It's also a moat for
a regrettable moat.
I mean, I think you could argue it's a good thing from a business perspective if you can get past, you have this moat around you it's harder for folks to break in. But I do think that that's also true of some of the entrenched incumbents of the healthcare world. Think, big insurance, think some of the complexities of clearinghouses and the power that those players have over just owning the pipes, because the pipes are so complicated and regulated. So that gets into some nitty gritty weird stuff around X12 standards for electronic data interchange, or EDI, which is also written into HIPAA. So it may not be the best way to think about exchanging information, but it's written into law. We've got it until, further notice. And so you end up with whole companies whose whole reason for being is just to clean that stuff up. And so that folks can outsource managing all that complexity, but that every one of those extra players adds cost to the system.
Hey everyone, we'll get right back to the conversation after a word from our sponsors. Today's episode is brought to you by Arbiter, the care orchestration platform. In a healthcare system full of silos, Arbiter is a unifying layer. Backed by one of the largest early funding rounds in health tech history, Arbiter brings payers, providers, and patients together on one intelligent platform, routing referrals to the best in-network option, managing authorizations and outreach, and coordinating appointments seamlessly. See how it works at arbiter.ai. So sometimes I think that we are very primed as an industry for AI because we missed so many waves of computing that maybe this somehow makes it make more sense for healthcare to be consumed by AI. And then other times I'm like, this doesn't make any sense because the same regulatory hurdles still apply unless we change all that and make these policies really amenable to AI, which could happen. But if you wrote a great little program that, say, did the exact thing that I talked about, that was a conversational chatbot to figure out what benefits you have, which would be a cool application for a company like yours to build, you still have to deal with HIPAA. It doesn't go away, right?
Yep.
So how does that improve efficiency for a business like yours? And maybe the answer is it works for some things and not others. And maybe the answer is it's still early, but would love your take on, do you actually think the hype is warranted?
I mean, I think we're still in the hype cycle, and I think a lot of it is warranted. I think about some of the interoperability stuff we were just talking about. That's much more of a back end thing. We'll get back to front end and chatbots, but just being able to say, take all this stuff in this format that I don't like and put it all in a format I do like, and the power of AI to help us do that is really useful. And so I think the complexity of data quality in healthcare and because of multiple different data sources, because of lack of standards, being able to clean that up quickly is really powerful. And I think it's really foundational for a lot of the stuff that we do. And then I think, to your point, I think a lot of what we're trying to achieve in healthcare as like a consumer of healthcare is actually like perfect AI use cases. It's like, as long as the AI knows where to go and has the right information, it's about like answering questions. It's very like Gemini, ChatGPT, it's perfect LLM territory, because it's like, hey, I need to know if Chrissy's in network for me. And then, I have a question about like, I want to go get acupuncture and I need to know how much it's going to cost me. And normally I'd have to go to 5 different places and do a bunch of math, because I have to figure out like from one part of the plan documents and compare to another part, and then go look at where I am in my deductible and all these other things. Like, it can just answer the question as long as it has the relevant information. Now, of course, you got to make sure it's safe and we're not like hallucinating for people. But I think the accuracy has to be better than human. It doesn't have to be 100%. I think that's a hard one for people to get over. But I think for me, it's really important that we're not doing harm and that we are accurate. But it's not that no mistake can ever be made, because mistakes are made currently all the time. And people are making them themselves. Really expert folks in the industry are always learning new things and making mistakes. So it has to be better than that, right? And I think there is actually a lot of utility there. And those are things we are doing. And I know others are building as well.
So I feel like as I'm hearing you speak about this, it feels like you are talking to me with more of a product hat on. But a lot of clinical people would sort of maybe bristle a little bit at the idea of it not being perfect, because of the tolerance to risk can be extremely low amongst clinicians. Like, there's liability to worry about. Medical practice and training is so conservative. And so as I was looking at the background that you have with wearing the clinical hat and the product hat, I wonder how much those things are in tension at times, where maybe the clinical side of the brain is like, no. And the product side of the brain is thinking, how do we design a way around this? And then how do you sort of find the right path between the two?
I love that question. And we didn't really talk about like my role at Collective being those two umbrellas of clinical and product. But on the clinical side, we have a care management team. We have a utilization management product. We have population health management and pharmacy programs. So those are sort of the clinical domains of what we do. And on the product side, insights, design, and product management. And to me, the merging of these two worlds has actually been much more synergistic than it has been at odds or in tension with one another. I think maybe that's partly because of the space we're in. We're a TPA within an integration ecosystem hub, so an engagement hub and a built-in advocacy and navigation.
Can you explain briefly TPAs? Because I feel like our audience, some people may know exactly what a TPA is, but it took me a while to like get a handle around what TPAs are. So what's your like very simple explanation?
Yes. So TPA stands for third party administrator. The best way to explain what we do is that we run health benefits for employers. So if you're providing health benefits for your people, we're like the platform that runs the health benefits and puts it all in one place. Medical, dental, vision, pharmacy, health funds, program like point solutions.
This is for, we should clarify, self-insured employers.
That is our current line of business. Yes, is all self-insured employers. And so they pay an administrative fee for us to run, because self-insured employers are like running a health plan and they don't want to adjudicate claims or deal with that level of complexity, right? So they want to select their plan design, but they want somebody else to actually administer the plan. It's kind of like the operating system for health benefits.
You're like the chief of staff for the industry. You do all the administration. you do all the ops, you do all the things, and then leaving the employers with the higher level strategy and thinking about how they want the plan to be designed.
Yes. And we partner with employers to help them select plan designs that work best for them and their people's needs. And of course, many of them have brokers or consultants who are at their side helping them design those things as well. But yeah, and then we run it. And kind of like how you can buy a phone and it's got an operating system on it if you have a smartphone, but it can run on different networks. Like you could get a phone and run it on Sprint, Verizon, AT&T. Our platform can run on different medical and pharmacy networks. So like a different pharmacy benefit manager or a medical network, whether that's one of the Blues plans or some of the national options. So we can plug in and run on those rails.
So when I was at my previous firm and on the venture side, did a whole piece of research where we looked at the TPA space with the question mark around, is this area investable? Is a new TPA business investable by a venture capital firm? So not a private equity firm, a venture capital firm looking for that like home run kind of exit that could return $1 billion fund. And the answer that we got to was no, because we didn't think that technology was enough of a lever with a TPA. We thought that the big lever really came from scale and leverage, which is kind of one of the big quandaries around investing in healthcare, that so much of it is about scale and leverage, but it is very expensive to build that because you have to build it through customer on top of customer on top of customer, where you have access to millions of lives. And with that leverage, you can start to do things like impact the cost of care. Pure technology without the lives, like I would argue, doesn't really get you anywhere. But if you had listened to my thesis on this, then Collective never would have gotten funded in the first place. And arguably in the time that we're living in now, probably would not have gotten funded either, because all we're doing right now is investing in AI. Believe like over 2/3 of all investments in the last quarter alone went to AI companies. It's basically sucking up all the capital in space. So as you think about the kind of reality that we're in, and maybe my thesis, which I'm sure would argue is completely wrong, but, tell me how we could start to think about investing in a company like a Collective, or even building a company like Collective that is solving a very unsexy problem that requires a lot of capital to be able to solve versus a shinier object.
It's a really good question. So we started with our founder and CEO, Ali Diab. He had a harrowing healthcare experience himself while on a self-funded plan and had hundreds of thousands of dollars denied, that he didn't understand what was going on, despite being a privileged and well-educated person of means, and felt like there had to be a better way. So we were never a TPA just to be a TPA. The TPA part was always a sort of a means to an end. And because we're the TPA, it forces, first of all, it's a must-have and not a nice-to-have for self-funded plans. So the other piece to it is that there's a bunch of logistical administrative pieces to it. So like your cards are in our application, your reimbursement for out-of-network claims is through us, the data all flows through us, through our platform. And so we know more in real time about people, and we have people's eyes and ears often before they're even accessing care. Like you search for a provider in our application, et cetera. And so the member experience, the front end piece to the TPA, was always a huge part of this. And it's always been the back end, front end story of tying those things together.
I think to your point as well, you mentioned the harrowing story. And I think he's quite a charismatic guy. So I think part of that, was there a piece of it that was the charisma, the personal story that was really important to getting something like this funded? Because even if the TPA is a means to an end, you still have to get behind building something really complicated and
expensive. Yeah.
And so, not everybody can raise money for that. Like, we're going to build this product that's going to take us years to build and sell customers that will take us years to sell. And so how do you do that, especially at a time when it's probably even harder to do it today?
Yeah, I mean, it's a really good question. And I'm not sure I have a perfect answer, Chrissy, but I do think that if you listen to PBGH, the Purchasers Business Group on Health, and Elizabeth Mitchell talk about this, she'll say what our people want are, when she's talking about her people, it's large employers, self-funded employers, huge purchasing power, huge market. And what they want is an independent TPA to be able to start to bring them as purchasers closer to the providers of care, the purchasers and the providers as closely as possibly linked without so much extra stuff in the way that just drives up cost and restricts their flexibility and control, which is a lot of the reason people go self-funded. And so I think that the administrative abilities do matter. And the market has spoken in terms of our growth over time. I mean, we only had a couple 100,000 members when I joined, and 3.5 years later, there's 700,000 and growing pretty quickly. And so I think while it did take some time to get to scale, at least, there was a pretty early product market fit for the friendlier, better member experience on the front end, but with the administrative capabilities on the back end to support employer demands and needs.
So what advice would you have of people listening who are thinking about doing something like this, where it's going to take time? It is a tough problem that relates to the underbelly of healthcare, the stuff that people don't see every day. You're not building a mental health chatbot. You're building a TPA. What advice do you have for people like that to be able to do everything that you all had to do to get this off the ground, which is very multifaceted, from the capital needs that we talked about all the way through to, to selling into a very saturated channel, which is employers, and then standing out in that market. So anything that you would share?
Yeah. I think this gets at there's some interesting writing about going horizontal versus going vertical in healthcare. And look, I'm not going to lie, going horizontal is hard. It's like the platform play, especially with the plumbing of healthcare and the size of the incumbency. It is hard, but I also think that there are a lot of cracks in the incumbent armor today that didn't exist all that long ago. What I would say is if you can find a way to leverage technology to allow for customer value, right? It's all about customer value. That's what product is all about anyway. It's just how do you deliver customer value in a way that grows your business? If your customers are employers trying to provide benefits for their people, they want the experience, they want the quality, and they want to manage out of control costs. It's hard to find a way to manage out of control costs without doing something that gets at some of the inglorious underbelly parts, as you said, of at least in healthcare, because those are the administrative levers, are the powerful cost saving levers that I think they sort of front end chatbot stuff. It's going to be hard to really show that type of ROI for the healthcare space. But I think what I was going to say there is that the incumbents are often, yes, big and yes, entrenched, but I also think they're sometimes limited by older systems and they won't have the flexibility. And so if there are ways with technology to show that you can do something that, big insurance, big pharma, the big industries can't do because they're too dependent on older systems that just can't be flexibly controlled, and you can offer that flexibility to your customers, I think that's the in, and then you can build out capabilities on top of that.
Okay, so last question for you, really around just getting the crystal ball out as best you can, and would love for based on what you see, which is really much more on the employer side, but you're tracking across the whole industry. We've talked about policy, we've talked about rising costs of care, we've talked about the consumerization trends, we've talked about AI. What do you think is coming around the corner that's interesting, exciting, that we should be kind of thinking about today and getting ahead of?
I think it's going to be some convergence of a lot of things we've already talked about, but I think, for example, better connectivity, interoperability is going to be a big opportunity for us and for others in the space. I think it will unblind lots of the blind spots that people have to what's going on for real patients as they bounce around a fragmented healthcare system. And I think that's the opportunity to tie together the real patient experience in a way that we have not really been able to in the past. I think AI is a part of that. I think that interoperability standards are a part of that. But I think like simple example is like stuff around patient access APIs, like being able to grant permission. Imagine you as a member on our platform could grant me or our company permission to access your records so that we have a more holistic view of what's going on for you beyond what we see from your claims, beyond what we see from your engagement with our application. That's incredibly enriching for our ability to try and predict your needs and to match what's available in terms of your benefits to your needs in real time or even ahead of when you are thinking about it or when you're making decisions. So I think that's a huge opportunity, and it'll take us a while to put all those pieces together and fully harness the power of that. But I think that's where this puck is going. And then I think a lot of other disruption follows, because I think there's, as we were talking about earlier, there's whole companies whose reason for being is just cleaning up messy data. So, I think where the puck is going as data quality gets better and those capabilities are available to a broader swath of companies and to earlier and earlier stage startups, I think there's a huge opportunity to disrupt a lot of the infrastructure of healthcare.
I love that. I often say that we kind of need a plaid. Like, why is there nothing out there that exists that you can just like every single other application in healthcare just say, I'm approving, consenting, like send my healthcare information or send this type of healthcare information to this app or to this healthcare, telemedicine business or whatever it may be. If you could imagine it being possible in a few clicks, just like it is in fintech and banking, where it's so easy to access all the financial information that you could ever want and need in a matter of seconds. And we do it in a way that is secure. So it makes me believe that it's possible with healthcare as well. If we made it work for our money, which is probably one of the most kind of sensitive things for people. So I love the idea that this is coming. You've given me some reason for optimism, especially as somebody who's been around for a while and seen a lot of false starts. So fingers crossed that you're right about that, because I do agree it would open up the sector in a really big way. Well, Ari, thank you so much for joining me on Lifers and for being a lifer, not giving up. I'm excited to see what you end up doing in the years to come.
Thank you, Chrissy. I'm a relentless optimist, despite all the challenges. And, it's an opportunity-rich environment.
And if all fails, then there's always the crypto or whatever the next thing may be. We'll have to check back in a year or two and have you back on.
Thanks so much.
That's a wrap on Lifers. If you know someone else grinding it out in healthcare, send them this episode. And if you want more unfiltered takes on digital health, check out the Second Opinion newsletter, link in the show notes.